if you as we're doing the discussion and thing, if you'd like to stay anonymous, please submit questions directly to us or if you don't want to speak out loud throughout the discussion. Throughout the talk, please feel free to message in the chat whenever you want to, whenever you have a question. We'll try and answer it then and there, because when it's relevant, it's so much easier to talk about it and relate it back to the cases we'll be talking about today. And if we don't get to answer your questions, don't worry, we have our events leads who will be collating those questions for the end. And the final point I'd like to make is that we will be discussing mental health and sexual health in this talk, so that's just a disclaimer there. So there'll be lots of sensitive discussions. So let's just get into it then. Okay. So to start us off, I have 3 cases that we'll be going through today. One on Omar, who's an undocumented migrant, Kalani, asylum seeker, and Amna, who is a refused asylum seeker. These names and these pictures are all fake, but the stories of these people are real, and they've been taken from the Equality and Human Rights Commission. So we'll be basing what happens in the UK, the healthcare inequalities they face, and some of the policies that make the NHS difficult for these people to navigate. We'll be exploring through these cases. So just to kind of go through these terms, because maybe some of you aren't familiar with them. An undocumented migrant is somebody who has come to the UK, maybe with a visa initially, maybe illegally in some way, or perhaps they had a residency but it's expired. Once those visas, etc., have expired, then they are classed as undocumented. If they've not submitted an application to the Home Office seeking for asylum, then they're also classed as undocumented. An asylum seeker is someone who's come to the UK seeking refuge from whatever they've escaped from, and has submitted an application to the Home Office. A refused asylum seeker is someone that the Home Office has rejected their asylum application. So actually, when I was coming across this, what I thought was interesting is in the research, people who are undocumented migrants, they're called undocumented migrants, but I don't think the government calls them that. Louise, could I just confirm that with you? I think they're called illegal immigrants, but I'm not too sure why.
Yeah, so you'll see this not just in like government policy stuff, but also in mainstream media. You know, the term illegal immigrants or bogus asylum seeker is another one, is thrown around quite a lot. And that obviously has, they're quite loaded terms, aren't they? By calling somebody illegal or calling somebody bogus, you're making inferences about their character. And of course, no human is illegal, and it is a human right to be able to seek asylum. And that's well defined in international law. What we do know, and I don't want to say too much too soon because I'm sure you're going to talk about it, but what we do know is the way that the Home Office processes and treats asylum seekers is based on an overwhelmingly hostile and xenophobic approach that the British state tends to take to migrants. And, you know, in 2012, Theresa May set out that she was going to create a really, really hostile environment. She said that when she was Home Secretary, in order to drive down migration. And that is, you know, decreasing migration is seen as something that's politically quite desirable, and you see that all the time in mainstream media as well, don't you? Migration is seen as a problem and not an asset. So in these sorts of discourses and in this governmental approach, the terms of, you know, people being bogus or illegal, they when you hear them, think about who's using them and why, and what might their agenda be. So they are loaded terms, and as certainly as advocates and activists and as medics, we should resist those terms because they are discriminatory and they don't have any legal basis. So yeah, I would say if you have to categorize people in this way, then something like an undocumented migrant is probably the best way to do it. Yeah,
absolutely. Thank you. So actually on that note, I will touch on the hostile environment policies now. So as Louise mentioned, these were set in 2014, but revised in 2016. And essentially what they aim to do is to criminalise everyday activities to make life really unbearable for people who are trying to seek immigration. Because according to the Home Office, their justification for this is people who immigrate to the UK are using up economic resources, particularly from the NHS. So they want to decrease things like health tourism. and have unbased, like, used research in not very good fashion, for example. So what they state that 0.3% of the NHS budget goes towards health tourism, when in fact many medics and health economists say that that's not actually true. There's no basis to say that from. So to give you an example, I have 3 points written out here to explain how these hostile environment policies are implemented. So first off is border control. So this is how everyday people are made to become border control. For example, people who work at banks, teachers, healthcare providers, landlords, they have to check that everyone that they are, and any of their clients, anyone that they're treating, have a residency within the UK, that their immigration is okay. And if it's not, they are allowed to then report that. So the NHS staff members can charge fees, and then also if the people have not paid their debts, healthcare debts, then they can report that to the Home Office. And what the Home Office can do after that, we will talk on this more later, but the Home Office can deport people and they can put people into detention centres, and they can also take away people's finances as well. And we'll go into finances now as well. So with the NHS, there is a 150% surcharge for people who are undocumented migrants and people who are refused asylum seekers. So the only people who get some funding support are people who are seeking asylum. But even then, and we'll go into this later because I don't want to give too much away, but some services in the NHS are open and free for everyone, asylum seekers especially, but some are not. So if you are seeking asylum, then you do get some asylum support, which includes £39.63, something like that. And that's given to each family member per week. But as you can imagine, it's not ideally enough money. If you think about how much a bus passes for a week, it costs at least like £5 for like a child or something, and then like more than that for an adult and stuff. And so these people end up living basically in the poverty line. And then the other thing that they're given for asylum support is accommodation, but they're moved. They don't have a choice in where they're put in the UK. So if they do make connections or are having continued support in a certain area of the UK, then for instance by their GP or something, if they get moved randomly, then that becomes discontinued. So we'll go into more detail about this later, but essentially the biggest point here I really want to emphasize is the surcharging. So when you come to the UK and you don't have any kind of residency or anything, then you have to pay a visa, immigration, healthcare charge, which is about £624 for an adult individual. And you can imagine these people who've escaped from whatever country they're from for whatever reason, whether it's because of their sexual orientation or because they've been prosecuted or tortured or something, they can't afford that much every year per person of their family. So quickly going on. So as a result of these hostile environment policies, they experience a lot of discrimination in the NHS. I'll start with discrimination, and discrimination on their race, on their immigration status, on their religion, and we'll talk about this more later, and especially on some of Louise's research. And then barriers to healthcare, like we'll go into this, language, technology, travel, there are so many, and then poor awareness, both from the healthcare side of things. So for instance, the NHS workers don't understand exactly how the hostile environment policies are being implemented in the NHS. And then also for asylum seekers and refugees, they're very confused. Like if nothing is in their language, how are they supposed to navigate the NHS? And then on top of that, the system is so complicated as it is, that they're always in fear. So on that point, I have a case for you. So this case is Amna. So I've given you a bit of background. So hopefully I'm going to ask you some questions, and then I'll release a poll. And on this poll, I'd like you, to use as much information as you can, but don't worry if you don't know if you've got the right answer, because that's kind of the point I'm trying to prove, is that this area is something that's really misunderstood, and therefore these people are really suffering at the hands of this. So Amna went through FGM as a child, Later on, she came to the UK, sought asylum, and has been here for 2 years, but it was rejected. So because of that, she stopped getting asylum support. So that was the £36 that I mentioned earlier. And now she's in poverty and she's completely homeless. She's since reapplied for asylum, and but she's not been able to obviously still seek any sort of financial support because she's being relocated in different places and she doesn't know whether or not her asylum will be accepted. She's pregnant currently, so she's quite heavily pregnant at 36 weeks. Her English is really poor, and so far she's been getting really poor antenatal care because of the fact that she can't speak English very well. So on that point, what delivery method do you think Amna should opt for? So Amna knows that because she's had FGM, it's going to make her delivery really difficult. And I'll just explain a bit about FGM as well before I open up the poll. So FGM is female genital mutilation. So there's different ways that a woman's genitalia can be mutilated. So for instance, areas can be sewn up together, areas can be cut off. And as a result of that, she's worried that her pregnancy is going to be really complicated. So to explain these options, the cesarean section is where the top of the woman's stomach is cut open and the baby is removed surgically. Defibrillation is where the scar tissue that is there on her genitalia from the mutilation is cut open a little bit to make the delivery a bit smoother. And an induced labour is where drugs are used to put a woman into labour artificially, so not naturally. So I'll just open up this poll and you guys decide what you think is the best option. So I've launched it now. So Amna has had a visit to the antenatal care. Doctors talked about these options, but she has no idea which one to choose. Which one do you think she should go for? Okay, interesting. Okay, so majority of you opted for cesarean section, and I completely understand why. It seems like the most safest option. But actually, what the doctor was actually trying to explain to her but couldn't get across to her, even with a translator available, was that the cesarean section defibrillation will both be completely safe and have no risk on her child's life. And induced labour, you guys were all correct. The majority of you are correct that that was not even one of the options there. So what I really wanted to explain here was that for asylum seekers, refugees, when they do eventually get to care, and we'll get to the barriers later on, but when they do eventually get to care, they find it difficult to explain the complexities of what they're feeling. So sometimes, even if you say you have gone through trauma, you have gone through torture and things like that, you don't start talking about it straight away. You need some time to be able to break that down with someone in a closed environment. You can't just have that on a one-off conversation with a doctor about what option you should choose for your pregnancy. So, and these come in other areas as well. So for instance, if you're suddenly ill on your pregnancy and you want to go to the pharmacy, there's no translators there. You can't talk to them, you can't explain what your needs are. And likewise, especially in this time as well, there's no translated materials for asylum seekers and refugees. There's minimal, but you can imagine how many different languages they're speaking. And for COVID-19, the government didn't do a very good job of releasing material for this. So these people were always scared. They didn't know where to get care. They didn't know when to get care. And even when material was released eventually by more like organizations and stuff, they were so scared to go and get care because of the hostile environment policies in the past and how they're worried about getting charged, they're worried about getting deported, that even when these materials and stuff were offered to let them know that they can get free healthcare for COVID-19, they didn't opt for it because they were so scared. On this point, actually, Louise, from your research, I know you have looked into language barriers. How has it affected access to care from your experience?
Yeah, good question. So Language as a barrier to healthcare access is pretty well described in the literature, and was well described before I started doing research on asylum seeker and refugee health. So my PhD looked at older asylum seekers and refugees' health experiences in the UK, and I'll talk a little bit about certain points from that this evening. But alongside the PhD, and what might be of interest to you guys in terms of developing a research career, I worked with Rebecca Farrington, who some of you may know. She's a GP who also works at the university, who's an expert in asylum seeker and refugee health, and a medical student who at the time was a fourth-year medical student, and as part of her PEP project, she chose to undertake interviews with asylum seekers and refugees about their access to healthcare. And as a result of that, we got two publications from that PEP, which is pretty impressive. So we asked the question, what barriers do asylum seekers and refugees face when they access primary care? And as you will know, provision of interpretation is a requirement. You know, how as a clinician are you expected to see and treat a patient if you can't communicate with them? So everybody is entitled to an interpreter when they attend healthcare consultations, but we found overwhelmingly people described that language was a barrier to care. So that was throughout the sort of journey of people accessing care. So people in our research described how English language literacy was a problem. So even sort of filling in forms to enrol at the GP was very difficult. People didn't read or write in English. Making an appointment to see the GP was very difficult as well. And then during the appointment, we heard stories of people's friends and families interpreting for them. So that raises issues of confidentiality. What you will be willing to say in front of your friend or family is very, very different than what you'd be willing to disclose to a doctor if you knew it was completely confidential. And then more worryingly, we heard stories of people's kids being brought out of school to translate because they were like the designated person in the family who was able to speak English. That's obviously, again, got huge like psychological implications for the child, learning implications for the child. And even despite that, we heard some pretty horrendous stories about how impaired access to adequate language provision impacted care. So in the paper that we published, there's a quote from a chap who went to the dentist and told the dentist that he had pain in his teeth. And he said, I've got pain in my, I'm going to read it out now. I've got pain in my teeth too much. I couldn't speak English very well and I have nobody to help me. So I'm very, very upset. I have pain. And when I see my dentist, they removed my teeth. When I come home, I say my pain is in my left side and they've removed the teeth on the right side. So we went back to the dentist and said, where is my tooth? And the dentist said, oh, I'm sorry, we took the wrong one. But because he wasn't able to communicate which side it was on, then, you know, that's resulted in inappropriate care, which is, you know, very, very concerning. This also has like more far-reaching effects on people's relationship with their healthcare providers and their trust of healthcare providers. And many of the people that we spoke to described feeling embarrassed and ashamed when they went to the doctor because they weren't able to speak English. And, you know, that's just not good enough. We need to be making services and in creating services and working within services that are a good fit for the most vulnerable people in our society. So yeah, language is a big factor and it's a big barrier to care.
Sorry, I couldn't unmute for a second, but yeah, I completely agree. Actually on that point, it kind of links in with the fact that they don't have much digital access as well. So for instance, like if they're wanting to make a booking or an appointment, doing that over the phone, going through a triage system like 111, or trying to get through to the GP in COVID times when you can't go to the practice and they can't speak English, they actually end up not getting even the care that they're allowed to get. And I've noticed that, especially in COVID-19 as well, like with more video consultations and things. They don't have the fundings to pay for, £36 does not cover internet access. It hardly covers data access. They need to prioritize other things like food or travel or other stuff like that. Or like with registration forms, for example, like if they wanted to get funding for their healthcare, then they can fill in a HC1 or a HC2 form. Again, that's like, as you mentioned, like when it's online and they're having to fill out forms and stuff like that, there's two barriers there in their way. One is a language barrier, and the second is the fact that there's a digital barrier.
Research was conducted pre-COVID, so that's a really, really good point. These times, although obviously they're not great for anyone, are they? But they're particularly difficult and add in barriers in ways that we need to think about, for more vulnerable populations.
So just continuing on with Amna's story is, so she managed to get accommodation. She's got it with a charity organisation who've offered her a temporary stay at their accommodation since she's homeless. But now it's come close to the time that Amna needs to give birth, and she's worried about where she should spend her money. She doesn't have money, she's completely destitute, and she's in poverty. So whatever little money she has left is what she needs to think about. Her accommodation is really far from the hospital. So here are her options. Should she spend it on travel? Should she spend it on baby supplies? Or should she spend it on food? So I'll open up this poll. So yeah, please vote where you think she should spend her money. Okay, a few more seconds. Okay, I think we've come to a bit of a standstill. So let's see, okay, 28 of you have gone so far, just like a few of you left. Okay, I'm going to launch the results now. So majority of you think it should go towards food. And I want to say yes, food. She complains, this is a quote from her directly. She says, "I'm hungry all the time. I'm tired. I need to eat. I need food. My worry is when the delivery comes, the place I'm living now, there is no one who can give me support." So in Amna's case, she does live really far from the hospital, but she does mention that if she lived closer, if she could choose where she could live, then there are people she could call on to. There are people who she could bring into the room with her, but she has no one that she can bring to the hospital. And they recommended that she does bring someone, but she can't do that. And she's worried that after her birth, there'll be no way to support her and her child. And this is a massive part of asylum seeker health that people kind of forget about, which is the accommodation, where they're living. And it reflects the hostile environment policies greatly. So it's very overcrowded, which is awful for COVID-19. And also, if you think about it, if you're trying to have a consultation with a doctor over the phone or a video consultation or something, there is no privacy. That, you know, confidentiality is really difficult to achieve. And these accommodation are notorious for being really awful and run down and in like just squalor, basically. And it sort of reflects the discomfort that the government's trying to put on them, that they shouldn't stay here, they don't belong here. And it really affects their mental health, because these accommodations, they set rules. And for instance, they tell asylum seekers to stay indoors for 23 hours a day, and they're not allowed to leave. And for instance, they even put regulations on making it more difficult for them to register at GPs. And things like that. So these people end up getting awful mental health issues because of where they're living. And you can imagine they're also isolated. They're moved randomly against their will at random points of the year. And when they're moved, they're disconnected from whatever social circle or community they met there. And they have to reestablish that somewhere else. And likewise, if they had some sort of care in, say, Manchester, they were getting it, and then moved to Leeds and they were getting, I don't know, cardiology care, that's really difficult to follow up on when you're an undocumented migrant, or like asylum seeker with no NHS number, no nothing, and you're moved to another random hospital or something. How are you supposed to follow up on that care, or try and go through the whole process again? It's really unfair. And I actually know, Louise, are you doing some research now on COVID and accommodation? I think you mentioned this to me before.
Yeah. So I'd like to echo your points first before I can talk a bit more about that project. But Poor accommodation in my PhD research, which looked specifically at older people, was something that people talked about a lot. Quite a few of the older people that I spoke to described being homeless in the UK, which really shocked me because, you know, you just think, especially older people who might be more vulnerable with particular medical problems, the thought of people being out on the street because the asylum accommodation has been removed is pretty worrying. So a lot of the people described how that homelessness had direct physical effects on them, so physical health effects, and as a result, you know, some of the people I spoke to ended up being hospitalised, but it also caused sort of more nuanced effects on long-term psychological health, where people would live with this sense of fear and uncertainty, which you described really well. When I spoke to women, they described how this sort of insecure accommodation and this in and out of homelessness made them vulnerable to sexual assault and sexual abuse. And some of the people that I spoke to had quite horrendous experiences of that in the UK because of insecure accommodation. I think what you're saying about the quality of accommodation is true, and that there are a lot of reports in the literature, so sort of what we would call grey literature, which is done by advocacy organisations where they collect stories and photographs and evidence of how poor this accommodation is. But there's also quite a lot of academic literature that looks at asylum accommodation and how it's used, as you described, as a way of putting people off life in the UK in order to, like I mentioned before, drive down that migration. So make the UK seem like it's not a desirable place for migrants. So if you're interested in this, Jonathan Darling is the person to read about. He was one of my PhD examiners, and he writes fantastic sort of critical theory papers about how asylum accommodation is used as a form of discipline for asylum seekers. So you referred to before the making people stay in for 23 hours a day. Now that is actually written into asylum policy. If people have had their asylum applications refused and they go onto something called 4.2 hard case support, then you have to comply with particular behavioural requirements. And those, I'll just read out from the policy now. And such conditions must be set out in writing. The person should also be given notice that they must reside at the accommodation provided to them and not be absent from it unless given permission. So this means, I mean, it's not prison, is it? Because these are houses or hotels, or as we saw more recently, army barracks within the community. People aren't locked in a physical sense, but they are in the sense that they are told to stay there. And if they're not there, we've heard stories of housing officers coming around and taking photographs to evidence the fact they're not there. So one older woman told me of how when she went out shopping, a housing officer came around and went into her bedroom and took photographs of her bedroom. And that's really intrusive thing to happen, and she was really concerned about that. She had a lot of traumatic life experiences, and the thought of a strange man going into a room just made her feel really insecure. The other thing to say about asylum accommodation is that it's not provided directly by the Home Office, and this is a clever trick used by the state to distance themselves from what happens in asylum accommodation. So as we're seeing a lot with COVID-19, the government contracts out to private companies such as G4S or Serco, which are security companies, the management of these asylum accommodations. So if you're interested in reading this more critical theoretical descriptions of these phenomenon, look at Jonathan Darling, and he talks about how that gives the government a bit of corporate distance, so they can't really be directly blamed, but of course it's all part of the bigger strategy of creating a hostile environment. So your original question, sorry, I'm waffling on now. So your original question was about my upcoming research project. Yes, I'm setting up a project with a team of researchers who are all sort of interested in asylum seeker and refugee health. And we're going to look at the Britannia Hotel in North London, which since COVID-19 has been used as an asylum seeker accommodation, for asylum seeker accommodation, like a form of provision. So up to 300 asylum seekers at a time have been housed in this hotel. And as a response, in response to that, a local GP practice have set up a migrant health service. And we want to learn about their experiences, because they feel that they've learned quickly and they've adapted quickly, but that they have a lot of experience that can tell us about how migrant health is embedded within broader health structures. In particular, we're concerned about safeguarding issues, which don't seem to be taken as seriously when they're reported about an asylum seeker or refugee, and also about how doctors who are working within that service, when they refer on to more mainstream services, how those referrals are received and how those patients might be treated differently. Charging aside, it's very, very difficult, we think, for these patients to be plugged into mainstream services, and we want to find out more about that. So I guess I'm talking about this as well to give you a broader sense of what medical research can look like. So it doesn't have to be labs, it doesn't have to be cells, it doesn't have to be quantitative research. My real research interest, and you'll get a sense of this as I talk tonight, but is in qualitative research, so asking the hows and the why questions, and in vulnerable groups and health inequalities. I guess if you drill it down, what I'm really interested in is like the power dynamics between service providers and service users. I think that's probably, if you had to say what is your actual, I mean, that's very, it sounds quite abstract, doesn't it? But that would fall under something like health services research. And there is a whole department at the university and a whole academic department that looks at health services research, which I've only found out recently. A lot of these things in academia are smoke and mirrors, but if you keep knocking on the right doors, people do have shared interests. They don't necessarily always, you know, I'm a geriatric medicine trainee, so I don't know of any other geriatric medicine regis who are interested in asylum seeker or refugee health, but that doesn't really matter. You've just got to sort of carve your own path, and we've put together this research team. There's a couple of trainee GPs, a junior doctor who's not decided what she wants to do yet, an ACF in anaesthetics, a psychiatrist. And so, you know, all of these people just have the shared interest in looking at how health services work for vulnerable populations. So yeah, there's plenty of work to do out there if you're interested.
I know, and if we've got time, I really want you to share your journey to that research pathway, because I think people here are really interested in how to get involved in, I guess you called it research activism.
Yeah, that's the thing. I need to stop rabbiting on, don't I? Otherwise.
So on that, Omar is our next patient. So he's was persecuted in his home country for being of a different sexual orientation to what was socially acceptable in that country. So he's come to the UK, and from what he was describing, it seemed as though he had underwent some sort of form of human trafficking and was put into a forced marriage. In that forced marriage, he managed to escape, and this was all whilst he was under the age of 18. So once he escaped the marriage, he became homeless. And because, of course, he was undocumented, he came in through illegal methods, I guess, through human trafficking. He was put into a detention centre for 5 years. After those 5 years, he decided to seek asylum and has been moved to asylum accommodation. So he was in London, and he's now been moved to Nottingham or somewhere. So I want to kind of open this up, and if you could use the chat, it'd be great. But if not, I do have a poll. What stresses has Omar faced in his lifetime that may impact his mental health? So from what I've described, it's not much, but what do you think are the biggest factors that are going to affect his mental health now? Either pre-migration or post-migration. You guys write down what you think are the biggest ones. Let's see what people are saying. Okay, isolation. Traumatic experience of being trafficked. Yeah. Being in immigration detention. Louise giving some big clues there. Yeah. So I'm going to open up the vote and I'm going to give you some options to make it a bit easier for you. So here are your options. Let me open up the poll. So I'm going to launch the poll. Do you think it's because he's going through an identity crisis? Do you think it's because of his destitution, so his poverty that he's experiencing being homeless? Do you think it's the violence he went through, or do you think it's the rape that he may have experienced being in a forced marriage? So let's see what you guys are voting. I like how Mehul wrote isolation. That's actually that's a big clue as well. Okay, I think we're coming to a bit of a standstill on votes. Give a few more seconds. Hamna said traumatic experience of being trafficked, and that is an interesting point. I'll have to acknowledge, but think more towards the other two. The hatred for sexual orientation. Yeah, that's also a very, very, very valid point. And that ties in with sort of the violence he experienced. Okay, so this one, I want to release the results. Let's see. So I think everyone's sort of gone with destitution is the biggest one, so his poverty that he's facing. And I'll tell you what he said in a moment. So let me open that now. So he said that the biggest factors that he felt was affecting his mental health was his identity crisis. So battling, he specifically mentioned his sexual orientation, battling against his faith and being rejected, his destitution in the UK that he's faced, and finally the violence he experienced when he was being persecuted for his sexual identity in his previous country. But what's interesting here is research has shown that if you compare the stresses, so the stresses that they faced before they migrated versus the stresses that they faced after migration, which ones are the ones that are causing their mental health issues the most? Which one are the biggest triggers, the biggest factors? And research shows it's actually the post-migratory factors. So especially, for example, like the process of seeking asylum is awfully prolonged. So these asylum seekers and refugees, in Omar's case as well, because he's trying to sort asylum, not only just the 5 years he's in a detention center, but after that as well, he's experiencing difficulties and being moved around. He explains that when he's being moved around and moved to different places, his disconnection from his family, his friends and his community that he had made in London really made him depressed when he was put in the accommodation later on. And the delay in the asylum seeker process, so that uncertainty whether you're going to be able to stay in the UK, whether you're going to be put into a detention centre again, whether you're going to be deported again, that uncertainty constantly feels like they're constantly dying every day. That's an expression someone's used before. It's like, unlike when they were in their previous country, they were escaping. There was like almost like a hope that things could be better on the other side, things could be, things could be improved. But when they're in the UK, they've reached that point now, but still there's no improvement. Every day is a day where it could be the day that they're deported, it could be the day that they're put into detention centres, it could be the day that the NHS decides to report them to the Home Office. And in Omar's case, he's scared that if he gets sent back to his home country, would he be prosecuted again if he's deported? So it's really affecting his mental health. And the most, for Omar specifically, he says that has feelings of fear, anxiety, and depression. And this is very common in asylum seeking refugees communities, particularly I want to mention on PTSD as well, as anxiety, depression are the most common mental health issues that are found. And how this sort of, the way that the anecdotes you hear from asylum seeker refugees tend to be, they tend to show in different ways. So for example, they have sleeping problems, they're having nightmares, going through fatigue, they feel threatened, scared and isolated all the time, a level of frustration, they can't concentrate, they're feeling overwhelmed. And this, of course, like you can imagine, leads on to self-harm. And that's actually what Omar starts to do as well. So Louise touched briefly on the detention centre, and I want to say absolutely, the detention centre is another awful part of the detention centre is that in every other sort of European country, if you're put in a detention centre, you're put there for less than 6 months. It's like a requirement. In the UK as well, that is a recommendation of 6 months. But in the UK, unlike other European countries, you can be left there indefinitely in a detention centre. And there are stories of families being separated and that having an awful effect on their mental health. And then also when they're in the detention centre, they're not got the same human rights. You can imagine they're not registered resident in the UK, and the government kind of uses this as a way of saying, okay, if you're not a residency, if you're stateless essentially, then you're not a human, I guess. So do you get health? They don't get as the same healthcare rights, and there are incidents of rape there and things like that as well. So I think there was also an incident of somebody getting their asthma inhaler taken away from them. So really traumatic experiences on that front. And Louise, could I know you have a specialist interest in detention centres as well, you know quite a lot about that, so could you touch on it please?
Yeah, sure. So you'll see tonight, I put this, I don't know if this will be to everybody, I'll just repost it. As we were setting up the meeting, this news came out that the Home Office has been found in breach of human rights regulations in the way that they've treated asylum seekers in detention centres. We've got one of the largest detention networks in the world in the UK, and as you touched on, we have sort of indefinite length of time that people can be detained for. Again, just like asylum accommodation, detention centres are run by private security firms. There's a lot of grey literature, as I mentioned earlier, and also there's some good documentaries as well, like panorama documentaries you can watch about what happens in detention centres. They're terrifying places and people live in fear of being detained. The point about post-migration stresses is really, really important. When I did my PhD research, I wanted to understand how older asylum seekers stresses across the life course impacted their health in later life. And I think probably like a lot of people, I assumed that people would be traumatized and made unwell by their experiences, say, for example, in Syria, you know, by experiences of violence and persecution in their countries of origin. But what I actually found, and what my research found, is that people are continuously traumatized by the hostile environment in the UK, and this is much more important to them than their experiences in the home countries. And almost paradoxically, people really miss their home countries, even if their home countries are terrifying places to be for them. So even someone like Omar will go through a sense of mourning and loss. The asylum system creates a sense of limbo, and that's how people articulated it to me, that they're sort of suspended in that unknowing space. Whilst you're applying for asylum in the UK and you're classed as an asylum seeker, so you have an active claim with the Home Office, although you are entitled to healthcare, so primary and secondary care, maternity care, this is all free for asylum seekers. Like you said, that can be taken away at any point. And as soon as that is taken away and you get classified as refused or illegal or bogus, then that's where the charging comes in, and that's really terrifying for people. The other thing is, when you're an asylum seeker and you've got an active asylum application going, you're not allowed to work. So people live in poverty, as you've touched on really well. And that worklessness, even for older people, is a huge thing. Whilst you're an asylum seeker, you're not allowed to apply for family reunification. So people are waiting to have their refugee claim granted before they're allowed to, or before they successfully get family reunification. So that's another really difficult thing. Often what happens is a male member of the family will make the journey to the UK, which can be dangerous and risky. And then once they arrive in the UK, will apply to have possibly a wife and children join them in the UK, and that can't happen until you've got a secure, or it doesn't happen until you've got a secure status. So this leaves people in a sense of limbo, and people describe to me like that sense of being hanging and waiting, and their life just passing them by whilst they're not able to do anything. People want to participate in life, they want to get a job, they want to get a house, they want to start building a life, and they can't while this is going on. And I spoke to people who had been in the UK for upwards of 15 years and still didn't have secure status. And so these are really prolonged trajectories, and this sort of uncertainty. So the asylum system itself and that constant sort of surveillance and monitoring and rules and regulations really takes its toll on people. And I think when we talk about how it affects health, you've got to sort of ask yourself, well, how could you be well if you were living under that system? It affects every everyday life, your sleep, your food, your ability to think straight. So yeah, the asylum system itself is very, very difficult.
Yeah, and that was just shocking hearing you say 15 years. So the next part of Omar's case is, where should Omar go to receive mental health support? So there's 3 options here. So this is from you've heard a few things from us, so you've given a few clues away as to maybe what asylum seekers, refugees are allowed to access, but you guys now are pitched to vote, so I'll open up to you. Where should he go? So just to recap, Omar is feeling very fearful, going through anxiety and depression, and is also self-harming. Where should he go? Oh, a lot of contention on this one. There's a big split. Okay, I'll wait for the last few people. Okay, I'm going to share results. So, majority of you voted for GP. So now I'm going to let you know what happened. So yeah, he went to the GP. And when he went to the GP asked him to give his address, needed to check his immigration status as well, and said that because of these 2 reasons, he can't register at the GP. Now, this is actually against what government guidelines says. So this is where the NHS has a lack of awareness on what refugee and asylum seekers are allowed. So a lot of GPs ask you to put an address in. This is really easily solved. The GP should just put in their own address if somebody doesn't have an address, and that's one of the things that they have to put on the system. But because of this, Omar becomes really confused. He doesn't understand why he can't get treatment. He thinks it's because of his asylum application that he submitted. So he actually removes his asylum application because he doesn't understand what's happening. So this is one of the biggest areas as well of lack of communication and deep confusion about trying to navigate this healthcare system. So just because of his lack of access to care, he's removed his asylum application. And this is difficult as well, because think about it, if say the GP did put down their address and he was moved randomly to another location, now the GP doesn't know where he's moved to, doesn't know how to give him his prescriptions, and likewise, say the prescriptions were sent to a local pharmacy. Well, during lockdown, pharmacies and GPs were closed. The system was different. The pharmacy would send the prescription over to the GP, but then the GP practice is closed. So where exactly are these asylum seekers and refugees going to pick up their prescriptions? And how do they know once they've arrived, especially if they move to a different part of the country? Then psychiatry services. So then eventually, after much difficulty, Omar was put through to psychiatry services, and he explained his situation, and he'd actually attempted suicide multiple times. and they said that his psychological issues weren't deep-rooted enough for psychiatry. He wasn't taken seriously. So this is a quote here from him, and it says, "Staff treat you like crazy. Their care is like a computer and there is no advice. I'm prescribed the same antidepressants and sleeping pills that I was unhappy and uncomfortable with. I feel as though I'm always playing to the rules of the institution, though I'm never provided any answers to my queries. Staff bend rules to their advantage. I have to fight for the little things." So what's really being emphasised here is the discrimination he's facing. In the NHS, people aren't taking him seriously. They're not providing him that patient-centered care that he desperately needs. And this sort of confusion and discrimination is also experienced in A&E. So Omar didn't go to A&E, but he's tried to commit suicide multiple times. It wouldn't be surprising if he did need to go to A&E. But A&E is another service that is free to asylum seekers and refugees. But even still, when they arrive there, they're expected to go through immigration checking, and again, what ends up happening is that they end up not getting essential care that they deserve to have, and it's free for them. So GP and A&E services are free. And in general, because asylum seekers and refugees have come from different countries, they find it difficult to navigate. So in their home country, perhaps you would go straight to A&E if you had an ailment or something and you wanted to see the doctor. You wouldn't go to a GP first and think about, is this a serious condition that requires A&E, or is this a lesser condition for a GP? They don't understand this GP system. So research has shown that asylum seekers and refugees access A&E services for less serious ailments and more frequently. But you can understand why. On this point of discrimination, we will be talking a bit more about how the institution itself, it's not just the perhaps the worker specifically, maybe they themselves, the NHS staff, is racist or something, or discriminating against their immigration. The actual system itself is very discriminatory. Louise, on this point, could you touch a bit more on discrimination specifically, if that's okay?
Yeah, so I guess discrimination, where to start? So like you say, there are incidences of interpersonal racism and discrimination that we have described in our research. It's not that well described in the literature in the NHS. I think this is a big area for future research, and I think the people's increasing awareness and attention to racism makes this a fertile ground for research. So that's a big hint to anyone who's interested in this and looking at research projects. So people's experiences of racism in the NHS is often described in terms of nurses who are being subjected to racism, but there's very little in the literature about patients being subjected to racism. However, what we know about the NHS charging regulations is that it is inherently a racist venture. What we've seen in terms of the Windrush scandal, it's an inherently a racist venture. So people who are minoritised in the UK are then targeted and asked to prove their eligibility for care, even though they may have been in the UK for 60 years. And if they're unable to prove that eligibility, then they can be told that they're not eligible, and they can be charged and run up huge bills and deported, imprisoned and then deported. So we need to understand better how this policy is operationalised. So another research idea, or another area that's in need of research, and one that I put a proposal together for, but unfortunately didn't get funded earlier this year, was how, so we know that when people are charged for care, there are things called people called overseas visitor managers who identify people who are chargeable for care in the NHS. So it's not necessarily, or it can be, it's not necessarily the doctors and nurses who ask, prove to me that you're eligible for care. It's often people who are behind the scenes. We need to know, how do they pick people who are chargeable? We suspect that it's using racist strategies. So they will pick foreign sounding names and target those people, but we haven't proven that. So that's why that is an area that's in need of research. Because if we can say, and this a little bit relates to your earlier point about you know, how research can be a form of activism and how activism and research intersect. If we can show that, or if that's happening, then we can use that to argue to end that policy, to show that that's, you know, illegal, unlawful, unjust, unethical. And so there are lots of, this is a fertile ground for research. I'll leave that there because I'm chatting on again.
Yeah, because actually on this point of charging, that is the next case. So it has reached 7:30. So this is the last case we're going to go through, just 2 more questions on Kalani's case. But feel free to leave if it has gone over time for you, and there is a feedback form for you to fill out. But going swiftly on to Kalani's case, she is a middle-aged woman, to late, and her husband has been tortured in their home country, and due to that they both escaped. And because of her husband's torture, he has very complex health needs that now need addressing. But since coming to the UK, and her asylum that she's applied for has given her some funding, but it's still not enough to pay for medications. So they're often at the interface choosing between medication or food. And her husband has decided that he only wants to pay for food. So what's happened is his health has become very worse now because he's not taking any medication, he's not treating anything that he has. And on top of that, he's experiencing a lot of treatment delays. And this is very much to do to the lack of understanding by the NHS as to who they should treat and who they shouldn't treat, who should they charge, who shouldn't they charge, things like this. So they've gone through a lot of delay. So they've, I think they've waited a year to see a consultant, and the consultant said that that he won't see them until their treatment is approved, which even I don't understand what that means. What does approval truly mean? So there's a lot of poor outcome here, and they're very scared that by accessing care, by using the NHS, that the NHS is going to share their information to their home country. So NHS will share to Home Office will send to their home country, and they'll get deported, and he will have to relive his torture that he escaped from. So what should the NHS Trust do for Kalani's husband? So they have a few options now, and I'll open up this vote. So for her husband, should they charge the treatment? Should they signpost them to the NHS low income scheme? Or should they deny treatment altogether? So I'll launch that poll. I think I momentarily showed the answer. I feel so bad. You're going to get this one right, but yeah, it's right. I'm going to. Oh, my sister's laughing next to me because she knows that I shared the answer. Oh my gosh, it's okay. So yeah, signpost to the low income scheme. So I want to talk a little bit about this now, the charging side of stuff. So yeah, cost wise, if they were to charge the treatment, what can they charge for? So outside of GP and A&E, once they're referred over to a specialist or whatever, that's immediately charged. And again, I mentioned before about the 150% surcharge on these treatments. So it's really, really high. And you can imagine these asylum seeking refugees are incurring a crazy amount of debt. And just to re-emphasize a few of the things, remember they had to pay for that yearly immigration healthcare fee that was like 625 or something per person in their family. Because of those fees and stuff like that, it means that families are separated. When they're moving to the UK, they have to leave. For instance, one mother described that she left her children behind because she couldn't pay for this fee. And on top of that, a lot of asylum seekers and refugees are double taxed. So they're paying the fee for their healthcare, but they're also paying this tax as well to get healthcare services. So to give you an example of what's charged, that would be things like ICU, mental health support, drug and alcohol treatment, community midwife services, which is shocking. It also explains, going back to Amna's case, why she had such poor antenatal care and follow-up. So the low income scheme, what that provides is the H2C2 certificate. So this H2C2 certificate is if you are under a certain threshold of household income, then you are allowed to get free dental services, free prescriptions, things like this, basically. So they can apply for this. So this should happen automatically, but sometimes it doesn't, and asylum seekers and refugees have to apply through a HC1 form as well, which we mentioned before about how complicated filling out forms is when you don't speak the language. So that's something that they do have access to. Now, survivors, say if you went through torture or you've been trafficked or went through domestic abuse, then there's a lot more open for that category is supported a lot more, which is a good thing. But as we mentioned before about Omar's case and how he went through human trafficking and stuff, even though this is in the law, it doesn't mean it's actually, de facto, it's not actually put into practice all the time. And if they were to deny treatment, this is very common. And again, I mentioned about the awareness. Treatment is often delayed for about 37 weeks on average, research has shown. And there's a sort of institutionalized disbelief when asylum seekers and refugees access healthcare. And it reflects the disbelief of when they're applying to the asylum application, that because they can't articulate themselves well, because they can't prove their entitlement in any way, that they struggle to be taken seriously. So they often, because of this hostile environment policies, because of the charging that they're having to be put through, they don't access care, and they'd rather go through home remedies, they'd rather take over the counter medication, things like this, until it's really, really severe, then they access care. Because the other part is that if they do incur a lot of debt, then the government, if they haven't paid that debt, I think in like 21 days or something along these lines, then the NHS can then pass on that information. No, actually, I understand what it is. If their asylum's being refused, asylum support stops at 21 days, and NHS information would then be shared as well. So that would include their debts, and that's used as evidence against them to put them into deportation or into a detention centre. So on that point, I wanted to ask Louise, this is going to be a controversial question, but if the NHS is a universal healthcare system, why are they having to pay up front? If the NHS in its constitution stated that everyone deserves free healthcare on point of delivery, why is this being implemented?
This is a big question. So basically, it's all back to the change in policy as a result of Theresa May's hostile environment policies. In theory, and Medact have done a report that provides a really good overview of the history of charging in the NHS. In theory, people who aren't able to provide evidence of residency have always been potentially chargeable for NHS treatment. Okay, so that was written into the way that the NHS was set up when it was first set up. However, what changed in 2017, I think it was, when the charging regulations came in, was that NHS trusts are now legally obliged to enact those charging regulations. And so if the NHS trusts don't comply, then they'll be in trouble. So that's the thing that's changed, because and before that, incidences of charging weren't so much as a problem as they are now. So the charging is one aspect of it, and at the moment, as you said, NHS care in A&E, in GP, for some mental health services and for some maternity care is free at the point of use for everybody, but there are exemptions built into that, and as soon as you incur a debt, then we're worried about data sharing in the NHS. So written into the 2017 policy changes was a memorandum of understanding between the Home Office and the NHS. Now, as student doctors and as doctors, we all understand the importance of patient confidentiality, and that people who come to see you must be able to trust that the treatment and care and the things that they're telling you stay between you and them. What that memorandum of understanding did was enable sharing of personal data between the NHS and the Home Office, which meant that hospitals became part of the border system, and they were used as points of closure, and then as ways of enacting bordering. We call it in like the sociological literature, you call it, the whole process of creating borders is described as bordering. So by introducing those processes into what should be like a therapeutic space, you introduce a whole host of problems in terms of professional obligations for healthcare staff, because it's completely in tension with your duties as a doctor. To think that the care that you might provide might result in someone being detained and deported. The ethical implications of that are huge. And as you referred to earlier, our understanding as medical professionals of how that is enacted is really lacking. You know, the policy documents that support this are very lengthy and impenetrable almost to people who are interested in it, never mind to your average doctor, nurse, who really, it's not their specialist area of interest. They're not bothered. They just want to get on with the job and treat the patient in front of them. So that sort of smoke and mirrors and like opaque approach to it makes it difficult to resist. Because if you're interested in making the care of your patient your first concern and resisting these hostile policies, if you don't understand how they operate, it's very difficult to do that. And just in case we're running out of time later, I have put in the Doctors of the World, what we stand for, the Safe Surgeries Toolkit into the chat. And as you guys go around your rotations and rotate through GP surgeries, this is one way in which you can resist, is you can ask professionals, and you can do it in A&E departments, how do you make your surgery a safe space for vulnerable migrants? And if they're not sure, if they don't know, you can point them to this. So you can print off these resources and take them around. And these are really straightforward basic steps which surgeries and A&E departments can take to make their space safe for vulnerable migrants. Yes, I think I'll stop talking about that now.
You really linked it well into the next slide, actually, which is on the data sharing. So
I feel like I keep doing spoilers.
You do a little bit, but it's okay because it gives them more information to be able to work out the actual answer. I don't really give them much to work out from. So this is the last question. How may the NHS share Kalani's information with the Home Office? So A is access the Home Office's checking service and hotline. Next is report non-clinical data, deaths and addresses. And then the final one is use the mesh algorithm, which I've not explained, but you'll find out shortly. So after this question, like after Louise and I have decoded all this, we'll open up the Q&A, so just give you an idea of how much time we've got left. Okay, this is interesting. Again, like big 50-50 split between two of them. Okay, I'm going to end poll and share the results. So a lot of you think it's the mesh algorithm, and I have to say it's actually non-clinical data that's shared. So I will explain this in more detail. So what the checking service and hotline is, I'll start there, is in the hospital themselves, there are people who are paid to do this immigration checking. So on one side it is healthcare staff, but then these are extra people added as well, and they're called immigration officials, or there's also another very specific name, overseas visitor manager or something like that. So they're paid about £60 per hour, which is significant, and I'll explain why. Because when people come to the UK and they're going through the system, the government uses hostile environment policies as an excuse to try and save money from health tourism or people abusing the NHS system. But it's actually shown that by implementing charges and having people to mandate those charges is more expensive than if you were to just open up healthcare and leave it free for all. That having these debt checking services and stuff like this, and having private companies run these services in the NHS trust is very expensive. So it's counterintuitive. It is just to serve the purpose of trying to decrease immigration in the UK rather than serving the NHS in some way. So this hotline service that they also provide, and this checking service, is where they can directly access, NHS staff can directly access the Home Office's data on whatever patient that they meet. And this hotline service costs about 80 pence per minute, and they can call it directly. And they determine, depending on very racist and discriminatory basis as to whether someone is deserving of treatment or charging or whatever. So it usually is based off what Medact think it's based off, as Louise mentioned, is how they look, how they sound, or their name. Then going on to clinical, non-clinical data, deaths and addresses are shared to the Home Office, and it's continually used to update their records. And at any time, the Home Office can act on that. This information is shared without the patient consent. So you can imagine why people are so fearful all the time. And debts are reported once, I think it's over when it's unpaid, under £500 for more than 2 months. So, and this information is used to like refuse visa applications again, deport people, deny their asylum, etc. Now the mesh algorithm I thought was really shocking. Because there's more evidence for this one. And what it is a message exchange social care and health system. And what this is it's an algorithm that gives people a code or a color, so red, green, or yellow. And this determines how likely that person is to be chargeable, because these people don't have an NHS number. So that could be perhaps put into the algorithm, but other things as well that Louise mentioned before. So what ends up happening is, through this, it works out within minutes, goes through multiple people on a database, and sends out letters saying people to charge people. And sometimes it's incorrect, so it does charge people who say already got a refugee status, or already their refugee status is when their asylum is being accepted. So they technically shouldn't be charged. They're not an asylum seeker, but they're being charged incorrectly. And going off by previous Home Office algorithms, this is a Home Office algorithm, there was like a Foxglove scandal and a JCWI algorithm scandal, and both of these algorithms that the Home Office used to go through their immigration processes were found to be racist and were found to be discriminatory. So there's a high chance that this system as well, this mesh algorithm, is also discriminatory as well. So I know Louise and I were discussing this before, that actually this is new information for her, and I think I've put in the references and a report that actually goes through these in a bit more detail if you were interested. So on Kalani's case, she mentions that I'll read it out to you. My husband was having blackouts and had problems with his heart, but we were really afraid to go to the hospitals. We didn't know what would happen if we went there, and they checked out our application status. So there were times we decided to stay at home and not go. We had to choose, are we going to die? Are we going to stay here suffering? So you can imagine like the fear and the difficulty she's experiencing with that. And on that note, I want to open up questions for Louise and myself. Thank you so much for listening.
Well done to everyone who's made it to the end.
I know, I'm surprised too. Thank you for staying, guys. Let's see the questions then.
If you feel shy about talking as well, just put it in the chat and we can read them out.
Yeah, I have a question sent in anonymously. So is there any way that we could get access to the recording of the talk? Yes, so I'll be posting this talk on our YouTube channel, and the link to the YouTube channel will be put on all our social media. So hopefully if someone from the committee could share our social media links, that would be really helpful. But it's basically I'll write it in, at Young Academics for Manchester. So that would be on Facebook, Instagram, and Twitter. So yeah, just a final point on, if you could please complete the feedback form as well, that'd be great. And that would lead you to the portfolio certificates and the handouts to the slides. So you have all the information that we've got here today and references, of course.
Should I finish off by saying something about how we might get, you know, if you're interested in these things, how you might get involved further? So
Yeah.
I definitely see research, as I guess I've alluded to throughout, as being a vehicle for change. So if you're interested in a social or political phenomenon that impacts health, that you think impacts health, or you have questions about whether it does or why it does, then I think that research and doing research in that area can be it provides a sense of legitimacy to activism as well, because you're generating evidence that can support your argument. So I think research can be a social and political force for change. So that's the first thing to say. If you're interested in these issues, then research can be a good way of using your time productively. There's also ways in which you can advocate for change more directly, and I've pointed you in the direction of the Safe Surgeries Toolkit. There are campaign groups that you can join, such as Medact, of which I am part in Manchester, Docs Not Cops, Migrants Organise, Patients Not Passports. There are lots of different campaigns that you can get involved with, where medics and non-medics alike sort of come together to resist these hostile environment policies. The other thing to say is that in clinical work, there are ways of resisting these things and advocating for change directly. So advocating for individual patients. I'm sure when you work within the NHS, you'll hear people say problematic things and make assumptions about people's lives that are incorrect and, you know, almost sort of part of that hostile environment. People become products of their environment, don't they? So it's about resisting that and challenging those sorts of behaviour, I find, which is tiring, but it's well worth it if you can hold people to account. There are other organisations, once you graduate, and maybe I think you have to be 5 years postgraduate, that you can volunteer with directly, such as Freedom from Torture, who are a fantastic organisation who provide medical legal reports for people who've been tortured. And there's basically a huge community of people that you can connect with online and then meet with, who are working to resist the policies and the health effects of the policies as well.
Thank you so much.
Hi,
go ahead, I'll ask a question.
Oh, hi. So first of all, I just wanted to thank you guys. It was brilliant. I really enjoyed the talk, so thank you so much. And I kind of had two questions. So first of all, I was wondering, like, in NHS, are there any doctors who do like some pro bono works for these immigrants? Like, is that allowed, or does that go against any regulations at place? Like regarding NHS, or like any codes of ethics or whatever, like guidelines is at place? And second of all, I was wondering, how do you think Brexit might impact the situation? Like, by any chance, if Brexit leads to privatization of NHS, like, is that gonna worsen the situation for immigrants, or do you think they're gonna like dedicate a private sector and like sufficient budget to this problem as like a whole issue?
Do you want me to take those questions?
Yes, please.
So yeah, in short, there are organisations, but there are voluntary organisations, charitable organisations. I'm just going to post in the chat one here. Doctors of the World is the main one, and they've got a clinic in London, and they are open to people who don't have, they're open to anyone vulnerable, anyone who wants to be treated, they're open to that. They don't do any sort of immigration checks. They're the people who I think are behind the Safe Surgeries Toolkit, but they run migrant specific clinics. So there isn't one in Manchester actually. I think the issue is I mean, you can undertake private work, of course, as an NHS doctor. I think the opportunity to make money out of this situation is both morally questionable and probably completely impossible, because I don't think asylum seekers have got much money to spare, as we've gone over in the talk. So I think it would be unpaid voluntary work. Freedom from Torture was setting up health checks, but I'm not sure how far that service has got off the ground. Brexit. So I don't know. I mean, I think the market effects of Brexit, I'm probably not, it's probably a little bit out of my competency to speak about. I think there's evidence of deregulation, isn't there, and increasing privatisation of NHS services. Not my area of expertise. However, I think what we'll see from Brexit is a lot of European people falling foul of these immigration regulations. So people who were from Spain, from France, from other European countries, then being asked to prove their eligibility for free healthcare in the UK, and so will fall foul of the hostile environment policies and be chargeable for care. The other paradox that you'll see is older British people who will call themselves expats, but are actually migrants who moved to Spain, who now will have trouble living in Spain, will come back to the UK, and they will also have problems proving residency. So you'll have people who are British born, who would consider themselves British, might also be trapped in that sort of hostile environment policy. So I think it'll be an interesting space, and more people will fall foul of it. Can't talk about privatisation. There are a couple more questions in the chat. Do you want me to read them out and take them, Connor?
Yeah, can I just make one point on the Brexit point, which is when I was reading up on it, with at the moment with migrant workers in the NHS serving the NHS quite a lot, they have been like removed from the charging, healthcare charging, and things like that. So in that sense, that's more of a pause rather than they've that's a complete policy change. So there have been a few different other pauses as well during COVID times, because of both Brexit side and because of this side, because I think with nurses especially, majority of our nurses are migrants, and they're not from the UK. So if you were to think about Brexit and getting rid of all those people, and then on top of that, making it a hostile environment to charge them and stuff, you can imagine that we're going to have a workforce issue too. So anyway, next question, please.
The next question, do you think there is a possibility for this to become a whole specialty within medicine in the future? So you mean migrant healthcare, I'm guessing. Yeah, do you know what? I would resist that, because although I think there is a need for a specialist approach, I think to create a subspecialty would almost facilitate, knowing what we've talked about how the NHS works. If you categorised people in that way and provided a different service, that service would then be very, very vulnerable. So Rebecca Farrington, who is like my hero, I keep talking about her, don't I? She's a GP with expertise in this, used to run a migrant healthcare service in Salford in a GP surgery, and the funding was cut. So over years and years, she built up this service and had the trust and rapport and specialist care provisions, and then overnight, bam, it was gone. So I think by creating a speciality in and of itself, you make it vulnerable to political flux. And I think the way things are politically at the moment, obviously, it just shows how then this can be, it can make people more vulnerable in a way. It's a bit of a paradox, that, isn't it? However, I do acknowledge your point that these patients are complex and need a speciality eye. I was at some Jerry's training today, actually, and we were talking about vulnerable adults. We were talking about people with learning difficulties, and how often when people with learning difficulties come into hospital, they have diverse and additional needs, and could be considered frail, so could have that complexity, and whether geriatricians are the best place to look after these patients. excuse me. And then as a side, we were talking about homeless people and how they often have complex medical problems, and whether, and I suggested something like a vulnerable adult service for that, run by geriatricians. But yeah, that's the, you know, in one way it'd be a good thing, but in the other way it makes it vulnerable, if that makes sense. Yeah.
One last question, I think, is
Yeah.
Is there where was it? Is there one thing in particular right now that people are campaigning for as a way to improve migrant health?
Yeah, there is obviously vaccine access. So there's a big campaign run by Patients Not Passports, I think it is, in London, and essentially all of the things that we've spoken about tonight come together and at a head in people accessing a vaccine. So you see people having language difficulties, having fearing accessing mainstream healthcare and thinking, is it worth it for a vaccine? There's a lot of vaccine hesitancy even without those features. How do you book onto a vaccine without giving your name, your address? Do you want to share your data? Can it be user tracking? So all of these questions are being asked. I know that some of the asylum seeking and refugee support organisations that I worked with doing my PhD are just setting up specialist vaccine clinics. So these are spaces that are already trusted by that community, and just people just say just turn up. So one in Bolton, in particular, I know of, that anyone of any age, if you're an asylum seeker or a refugee, can just turn up. But I know there is concern that these vulnerable populations will be left behind, and there is quite a lot of active campaigning going on, led by the London team. What else? I mean, there's Medact centrally, and the migrant health team at Medact have got their finger on the pulse, and if you are interested, I would suggest joining Medact via the central London team, and we run a smaller Medact group in Manchester if you're interested as well. So have a look at their website and sign up to their email notifications.
Brilliant. I think that brings us to a close. Thank you so much, everyone, for coming. And thank you so much, Louise, for helping me do this talk, mentoring me through it all. And being
I feel like you deserve a special thanks and special recognition, because you led it completely, you structured the way it was presented, you knew what you wanted to say, and I'm very, very impressed. I think you've been fantastic. Thanks for inviting me. I've really enjoyed it.
Thank you. All right, take care, everyone. I hope you have a lovely evening, and if you're fasting, I hope you can go break your fast now as well. Take care.
Hey, can I quickly ask something else?
Yeah, sure.
Yes, sorry if I'm keeping you guys, but you know, I was just like, after your talk, I was just thinking, I just had a quick idea, but like I'm not sure how great or conductable is it. So basically, I was thinking, you know, at the beginning when you mentioned the issue with interpretation and like language barrier and everything. So I was thinking, like, what if as a students we do like collaboration with student-led societies at the university. So I like, you know, there are some societies like Persian Society, or like some, you know, some like some national societies. So what if we do like a kind of student scheme where you would like match up a student with like somebody, like some migrant in needs of a translator, so that they can help out with like medical issues like during the practice, or like even online by a volunteer basis.
Yeah, that is such a good idea. I think it might have already been done. So let me put in the chat the group that are in chat. Oh no, that's not. Wait, one second.
No worries.
There's a group in Manchester called Multilingual Manchester. and it's a fantastic, oh, why is my internet working? It's a fantastic research group who, I think they started out just documenting all the languages that were spoken across Manchester and celebrating it, whoops, as a multicultural city. But they have got projects like this. So I would reach out to them, drop them an email and see what they've got going on at the moment, because it might, do you know what, with COVID and everything, it might have slowed to a stop, and you might have an opportunity to, if it's not going, reintroduce the idea, or, you know, plug yourself into it now. So yeah, it is a fab idea, that, isn't it? And it definitely, it feels like there's an untapped resource, doesn't it?
Yeah.
So multilingual students and people who care and want to do something, and then like a practical response to it. There's also a really good, although I guess if you're a medical student, it might not be as, I don't know how, whether you might be able to get involved with this. There's called an organisation called Reach at Salford. And Reach are an organisation that mentor refugee doctors. I don't know if they do it for maybe not medical students, but or maybe just healthcare professionals. I'm going to put this in the chat as well, because this is another direct action you could take, and you can be a mentor, or like, I guess I don't even know if it has to be a mentor mentee sort of dynamic. Maybe it could be like a collaborative partnership dynamic to a doctor who's fled persecution, come to the UK and is yet to get into work, helping with all sorts, you know, job applications, English language exams, things like that. So that's another really nice way you can be involved in like a personal sense with that community.
Yeah, and I know of one on that point, actually. I know of another organisation, something very similar, teachers, runs teaching sessions to help healthcare staff to understand how to navigate the system, and it is run by students, if you're interested in doing that. So I have the email address. If you could just send me yours, and I can't access my internet right now, but if if you send me your email address in the chat privately, then I'll send that to you if you're interested.
Fab.